Good afternoon to everyone on the East Coast, and good morning to everyone Central and over. I think we're going to go ahead and get started. So I want to first thank you for joining the HCAG webinar series. The Healthcare Executive Group, now in its 26th year, is a national network of select healthcare executives and thought leaders who navigate the tactical and strategic issues facing organizations today and provide a platform that promotes healthcare innovation and the development of lifelong relationships. Originally known as the Managed Care Executive Group, HCEG was founded by healthcare executives looking for a forum where the open exchange of ideas, opportunities for collaboration, and transformational dialogue could freely ensue. Currently, we're planning our 2016 annual forum, September 12th through the 14th in New York City. Contact information for the event will be provided at the end of the webinar. And just to introduce the Change Healthcare Consulting, Change Healthcare Consulting partners with our clients to define a clear path forward in the complex maze of today's healthcare environment. We are focused on enabling smarter business decisions to help you anticipate and navigate change. In support of this objective, we work side by side with our clients to define new strategies and bring them to life, unlocking the opportunities created by a shifting landscape. And today's presenters are Tom Cuccia, Managing Director of Valuation and Transaction Advisory Services, who will be presenting on the business strategy of payer-provider integration, and then Bob Hoover, our Director of Population Health, who will be talking about the technology aspect of the payer and provider integration. And then before we get started, I do want to encourage you that if you have any questions throughout the webinar, please submit them through the Q&A screen. You can find that by either selecting the Q&A button on the upper right-hand corner of your window, or if you're in full screen mode, you may need to click the drop-down arrow on the right, and then you can select the Q&A panel from there, and we will have some time to answer questions at the end of the webinar. And with that, I will turn it over to Tom Cuccia to address the business perspective of payer and provider integration.
Good morning, everyone, and thank you, Chris. As Chris mentioned, our focus today is going to be on payer-provider integration. And before I start talking about some of the macro trends, I wanted to provide some of the statistics that underlie and support the trends that we're seeing. So the American Hospital Association, next slide please, reports that in 2014, 13% of all U.S. health systems were offering health plans. And to do that, there were significant challenges that they had to overcome, not the least of which was the degree of payer-provider integration that was necessary to achieve success. One of those obstacles is I think they need to clearly delineate their value proposition and their brand identity. This is especially true when the providers are offering a narrow network. Other challenges that we've seen is the coming together of care quality and outcomes being tied to reimbursement. And then to draw an analogy to the real estate market, what defines success in real estate is location, location, location. I think in healthcare, we're coming to realize that what defines success in healthcare is data, data, and more data. So the challenges around data, of course, is it in my electronic medical record, first of all? And then if it is there, how do I extract it? And then how do I interpret it? And these are some of the questions that we're going to be delving into a little bit later and that Bob will be able to address. Further along the statistical path, we've got 50% of healthcare systems have applied or intend to apply for insurance licenses, and 70% of those systems are reporting a shift by payers to a value-based payment model. Another major trend that we see is increased consumer involvement in healthcare. That manifests itself through price transparency, not only with what our physicians are charging us, but what hospitals are charging us for procedures. I think negotiating fees is becoming much more prevalent, and again, this is not only with our personal physicians, but with hospitals. And then asking why diagnostic tests are needed, I think, is another area where consumers are becoming increasingly more involved. Why is the test being requested? What will it tell the physician? And how will the physician use that information to provide better care for me? Another area that physicians are reporting on is the prevalence of value-based payment models. 50% of physicians are fully expecting, or approximately 50% of physician compensation is going to be tied to value over the next 10 years. The doctors are understandably a little bit nervous about this. They would much prefer the fee-for-service status quo. They're very careful about assuming financial risk and losing control over their income streams. Another factor that I think that is leading payers to align with providers is information, excuse me, that was provided by CMS. They forecast that Medicare and Medicaid enrollments are going to grow by 57% and 71% respectively from 2006 to 2022. And that's contrasted with enrollment in private insurance. It's only going to grow by about 6% over that time period. So what we see then as providers, or as payers are aligning with providers, is the payers are developing exchange networks and they are exchanges for selling their health insurance. They're aligning with providers through the creation of narrow networks, which are helping to reduce costs. But the counter to that is they're also excluding the more expensive providers, and that they're negotiating rates downward for those that remain. Other important factors for carriers are to eliminate the high-cost hospitals, and that's usually the high cost of the price leader in any given market, and oftentimes that high cost or that price leader is an academic medical center. So I think what we're going to see there is increased pressure on the academic medical centers to lower their fees to stay in the network. What's been the patient response to all this? Well, they're clearly happier about lower premiums, but I think patients are also a little angry about the fact that their physicians may no longer be available in the network, and they're also angry about having to pay higher out-of-network costs for certain docs, even if they are in the hospital network. So when it comes to payers renegotiating or negotiating lower rates, I think all the indications that I've seen are that United Healthcare and the Blues are sort of leading this charge. And as I mentioned, the providers that are especially vulnerable are the price leaders in any given market, such as the academic medical centers. What's also interesting about this push for lower costs is the conflict that it sets up. All the carriers and the systems both are stressing population health management. However,
you seem to have lost Tom. Give me one moment. I'll try to figure out what happened. Just to check if the audio is working, would any of the participants just send me a message over chat, let me know if we still have audio. We seem to have lost Tom. If that's the case, we'll go ahead and move on to Bob's portion. If Tom is able to rejoin us, we'll loop back around. I just want to confirm that we're still here. Okay. So Bob, I'm going to unmute you and I'm going to advance to your section, and then hopefully Tom's able to rejoin us and can pick back up. I've sent him an email.
Can you hear me?
Yes, I can hear. I can hear you, Bob. Let me get this set up. Okay. And then I'm gonna let you go.
All right. So, sorry about that. It's interesting. I'm going to talk about technology, and here we are having problems with technology. I guess that's the way it works. Tom was focusing on providing us with the overall macro level business trends and really what's happening in the industry, driving us to have changes in the business model, more alignment between payers and providers, and even we've been experiencing. Now, I'm going to focus more about planning for the technology that's required to support these new business ventures. So why don't you go to the next slide, Chris? What's really interesting, represented by two of these quotes, is that technology is a requirement and to enable change, and the change we're really looking for is dramatic and dynamic, and we can't think about affecting this change without technology enabling it. And the last quote by another famous individual named Bob Hoover, I remember being in this business and talking about trying to accomplish things, but sitting in the room, well, technology can't do that, technology can't do that. We have to wait. But technology is no longer a limiting factor. Technology, and we all know it's pervasive. It's amazing in what we can do and the changes that are impacting our lives every day, and how other industries are using technology to really understand and drive changes in performance, changes in business models. It can't be the limiting factor for us, and it won't be the limiting factor. It's really how we implement it, and so that really moves us to the next slide. We're really talking about planning, and to sum up with some of the things that Tom was saying, again, from a business perspective, we really see CMS has been leading the way in some of these fundamental changes, whether it's been through the ACA, expanding insurance, creating new business models, or the Center of Medicare and Medicaid Innovation, value-based payments, and all the projects and programs that they're trying to initiate, really to impact the overall cost of healthcare and the continued growth of the GDP spent on healthcare. The states have been pushing this as well, because the expansion of Medicaid and the cost of Medicaid, and specific examples in California, Maine, New York, but all states really looking at better ways to control the cost. Private sector has taken advantages and led in some instances as well, but just recent examples, Horizon Blue Cross and their bundled payments, and Aetna, Anthem, and United are all implementing programs, and Tom talked about moving to value-based payment, moving away from our fee-for-service model. And one of the leading models that has emerged in this new world is the ACO, the Accountable Care Organization. That organization, focusing on the tenets, the principles of the AAA, improved health care, reducing costs, has kind of been the focal point for a lot of these initiatives. And really, and you think about it, and again, I've been in this industry a while, been through capitation, I think, multiple times. And the problem with capitation, when it was implemented, I think in the 90s, late 90s, we didn't have the systems or technology to really support those models, and taking on risk and sharing risk and managing risk proactively. But today, as I said, I think the technology is there, and we're better positioned to support these new business ventures. So moving forward, next slide. It's interesting, and I think for those who have been in this industry a while, we've seen this. A lot of times as we think about new business models, new ventures, new requirements, people focus on the shiny new toy, or what I call solutioning first. And really what we need to do before we get to that solution is we really have to think about what we're trying to accomplish from a business perspective. What is the business model? And these business models that are emerging, while the organization and entities might have existed, but how they work together and cooperate and collaborate is very different than they have in the past. So the ecosystem is different, and the ecosystem can be very different based upon the location and what organizations exist in the region, the location. We need to understand how these organizations are going to work together, and more importantly, as they work together, how they're going to align incentives to ensure that the outcome is what they desire. And the change that we're looking for is dramatic, and it doesn't happen overnight. And what we have to do is make sure that we establish kind of interim goals and interim steps, and we measure along the way. One of the keys that we see is really defining use cases for the flow of the patient information, because in these new business models where we're having organizations from a lot of different care modalities work together to manage the patient, the flow of information, and it needs to be patient-centered, and we need to understand the flow of the information as the patient goes through the system. As we think about these models, we think about the division of responsibilities across the organizations to ensure we understand the roles and responsibilities and what capabilities these organizations are going to need. And fundamental to these organizations, and we're going to talk a little bit more about data in the next couple of slides, is the concept of information architecture. And data to use not only to support the delivery of patient care, but the analytics and of the population, and supporting the measurement of performance moving forward. Next slide. So we talk about these new business models. We need to understand the business drivers specific to the initiative, the entity, the organization that you're involved in. Specific questions to address: what populations are we focusing on? Is it the Medicare population to support a Medicare initiative? Is it the Medicaid population? Is it the commercial population? Or is it the individual market of the brought on by the ACA and exchange? Or is it an employer that you're focusing on? For this new entity, what are the defined goals? Are the goals related to cost, or are they related to cost and quality of care? And what are the specific measures, the targets that you're driving to hit? So that, again, we're going to talk about measuring performance. And as you bring these organizations together, the plan, the provider, the home care, all the organizations involved in this venture, what are the functions that each of these organizations are going to support? Is it care delivery? Is it care management? Is it a specific component? And who's going to support the administrative tasks to support this new business model? Specific focus is on care management and managing the health of this population. It's really about the quality and the cost. And again, healthcare is local. These business models tend to take on the attributes of the organizations locally. Is it a single organization? Is it multiple organizations? Is it, how are they going to align? Is it contractual in nature? Are they affiliated? How does that work? Again, understanding that so that you can design systems, design incentives to be able to manage to that. And one of the questions that we always ask is understanding, is this, as you're talking to various organizations, what percentage of their business is this population that they're managing? Because, change is easier to impact when it's a larger percentage of the population that they're managing. Go ahead and next slide. I think Tom would have spent more time on this. I'll just briefly touch on this. Incentives are extremely important to align and manage behavior. what's really important as you design these models and you implement these models, that the overall incentives are understood and they're transparent to all involved in these organizations. At times, incentives are defined for you because you're managing to maybe a government program, Medicare or Medicaid. Maybe it's something that you're defining based upon the commercial population or the employer employees that you're managing. Again, Tom would have spent a little bit more time on the incentives, but again, we said history has shown that if it's a larger percentage of the population that you're managing, it's easier to get the change. At times we've had to, when you think about changing for a specific book of business, how does it impact the practice overall? Are you going to manage a Medicare population, a Medicaid population, a commercial population differently than you manage your entire book of business? And generally the answer is no. So as you think about the change in the organization, you have to think about, I'm going to make changes to improve the cost and quality of these populations. What's going to be the impact of this other book of businesses? And chances are you're going to float the boat and improve performance maybe for your competitors, but in order for you to get the impact that you desire, that's something that's going to happen, and you're just going to have to live with that. It's not just about technology, more so it's about the technology and the workflow and how you use the technology within the practice to achieve the desired result. And the other thing I think we have to remember, specifically within the incentives and the goals and objectives, are providers are very competitive, and at times they react to peer data. So, showing them how they're performing against their peers and using that data, and again, data to measure performance, to educate, and helps drive changes in performance and gets back to their ability to change. Next slide. Fundamentally, a key difference in a lot of these models, and this has been happening over time, care coordination. Care coordination really is to support the overall management of the health of the population, and it's really a component of some of the models that have emerged over the last 5 years, the patient-centered medical homes, the health homes to support the Medicaid population, ensuring that care is coordinated across all those care modalities, and having the technology in place to enable that care coordination. The models vary as to who pays for the care coordinators and actually where they reside. So we've seen it where the care coordinator is funded by the health plan, and but they're employees of the practice, or that they're employees of the health plan. Again, it gets back to what works in your market. Technology, as mentioned, has to enable the care coordinators to perform their function, and that is seeing what's happening to this patient across the ecosystem, having access to the care plan, having access to the patient-level information to ensure that everybody who's providing services to that patient is supporting that overall goal, the care plan, and it's not just that the care providers can see the patient record from an efficiency perspective, they need to be able to update the record so that, again, all people providing care see the same picture and can be aligned to the overall goal for that patient. Next slide. So we've been talking about planning, and I'm big on planning because, again, just going and applying technology to a solution, not understanding what you're trying to accomplish, chances are you won't succeed. So we start with understanding the business drivers, we set strategy, and then we define business requirements. And the business requirements for these models, multiple levels, and there are differences. First, we have information needs and requirements to support the delivery of care. And generally in these types of environments, the providers have their own EHRs, and they're using the EHRs to document treatment and to access information. We also need to understand and provide interoperability of this data so that it can follow the patient. We talk about following the patient. So we have point of care, real-time information to support improvements in care delivery. The second level of business requirements, analytics and data, specifically to support the population health management. And I'm defining that as aggregation of data and then analytics to support assessing the risk of the population in terms of your ability to be able to define interventions to impact the health of that population and impact the movement of earlier in the history of that patient so that you keep them out of the chronic conditions. It's a goal. In addition, from an analytics perspective, we need to support the ability to measure both quality and cost attributes of the patient and the health of the population. So analytics both from a risk management perspective and then from a performance perspective. And the last level requirement in these type of initiatives is understanding the administration of the model. And traditionally some of the administration of these models has fallen back to the health plan in terms of enrollment, claims payment, and aggregation of data to support whether it's HEDIS, NCQA measurement, those type of requirements. Again, those are the roles the health plan has traditionally played, but in these new models, having that discussion up front to ensure that you understand those responsibilities moving forward. Next slide. I've been working with a few ACOs. A friend of mine runs a very successful ACO in the Buffalo market, and he summed it all up in saying it's all about the data. Having the data to understand what's going on with your population, the risk that it presents, measurement, using the data to work with the providers to impact performance, using the data to measure performance, to incent the providers to change behavior. It's all about the data. But we have challenges with the data. And the data that exists, the federal government incented providers to automate through the ACA, but just because they automate it doesn't mean that the data is in a way that's able to be used universally and uniformly. So the long-term vision is we have standard, discrete, and discernible data, but we have a long way to go towards that. And a lot of what we need to do in these organizations, in these new ventures, is work with providers to define the data requirements, to help them improve the practice to move towards that long-term vision. We'll talk a little bit more about that. Healthcare, how do we move forward? Healthcare is local, we all know that. Understanding the ecosystems that your organization, these ventures operate in, and the opportunities that might present themselves. In certain markets, there's a dominant player, and that dominant player is defining standards, and you're leveraging those. In other markets, there isn't a dominant player, and there might be an HIE in place that's providing specific roles for interoperability and transferring the data. But understanding what's going on in your market, what's happening from an exchange perspective, and how you might achieve interoperability is important. Mentioned this before, defining the requirements for data. It's all about the data and making sure that you understand what is the data that you need and working with organizations to begin capture and improving the process of the capture and the quality of the data moving forward. Leveraging available standards is extremely important, and there's a lot of standards. And again, the Fed, while they haven't set the standard, they have pointed towards the standard, the CDA, the Continuity Document Architecture, and the CCD underneath that, really, that's being managed and governed by HL7. we're moving towards those standards and using those to transport that data. And again, the long-term future is discrete discernible data elements using that standard to get there. And and the doctors will say that providers will say that the data still needs to support text, and within those standards there's opportunities for leveraging text. Understanding the vendors involved and ensuring that they participate. We don't build systems by ourselves. We build things around. We're leveraging and we use and depend upon vendors in this marketplace. So understanding who those vendors are in your ecosystem, where they are in the terms of supporting standards and the interoperability of data, and working with them to align to your plans. They have a tough job, and they aren't where we need them to be, but you need to invest the time in working with the vendors to enable them to achieve what you need to achieve. Lastly on this slide is supporting for providers. And in a lot of markets there's still small groups and individual providers, and really you need to figure out, in addition to the care coordination, supporting them, coordinating care, you need to figure out how they're going to be able to manage their technology, how they're going to be able to access the data to affect the change that you need, how they're going to be able to input the data in their systems and allow that to be interoperable to support your overall needs for population health. And it's not just the implementation of technology, but it's also the support of the providers on an ongoing basis, and that has to be a part of your plan. Let's go to the next slide. So a concept I mentioned earlier, so it's all about the data, but you have to figure out how you're going to manage data. Managing data in your own organization at times is difficult. Now you have this complex ecosystem that involves, or potentially can involve, disparate organizations not owned by the same organization, not only aligned through this integration model. Well, the concept that I like to introduce is information architecture. And it's a component of an overall enterprise architecture. What's unique about this is it spans multiple companies, and it's a hard thing. But understanding the data and how the data needs to be captured and transported across organizations, and where it needs to be aggregated to support your population health initiatives and your performance measurement. Now, we're involved in a project right now that we're supporting an HIE and their overall data governance. And it's bringing the parties to bear, establishing governance, establishing data quality standards, and defining requirements. It's not about having a central system necessarily. It's about understanding where the data is, how it's managed, and how you're going to access it, and then manage that on an ongoing basis. And this is, one of the most important things, and it's one of the keys to success: information architecture. Next slide. So we have a strategy. We're defining requirements, we're understanding the data, and now we start to talk about the technology. And before you go and buy that shiny new object, which I talked about, now it's assessing the current capabilities. It's understanding the environment that you're in, the organizations, what systems do they have, and how can those systems support your functional needs? How can those systems support the overall goals of the organization? What technologies do they utilize? What is the relationship to the vendor or supplier that these organizations have? What is their compliance with interoperability standards? Again, having that data flow across the systems, you can access it to support care delivery and population health analytics. What technical and functional resources exist? What contractual terms that you have with the vendors, and can they be leveraged? You need to understand that. You know, we generally then create criteria to assess whether or not that these technology components that exist in the organization can be leveraged by this new enterprise, and before we go off and buy a system. But you know, generally we call this an inventory process, where you're defining the technologies, the systems, the capabilities against your requirements to determine whether or not you have to buy something new before you go off and start that process, and or whether or not the contract and the technology allows itself to be applied to the larger organization or this new initiative, and whether or not the partners agree that these systems can be leveraged in the way that this organization needs. So we've assessed the capabilities before we go off and buy the shiny new toy. Next slide. I like to say it's about people, process, and technology. So, buy the shiny new toy and implement it, and without, the new processes and the resources aligned to that, then you're generally going to fail. So as we think about, assessing the capabilities, you need to understand the resources that you'll need, and the resources that are planned in two ways. Both, one, to support the implementation of the initiative, of the technology, of the business model, but more importantly, on a go-forward basis, how it's going to be supported. And again, as these ecosystems include provider offices, how you support those provider offices in the use of technology. So from your assessment, you're going to have to map your existing resources and the roles they play, the capacities that they have to support this initiative, and identify that. And as I said, it's not just the implementation of the new technology, but it's also the support on a go-forward basis. And these plans have to be multiple years. So, as you support the providers in this new initiative, who are they going to call when they have questions about data and the interoperability of the data? As you look at your model, I always tell my clients, you need to understand what your core competencies are, and you need to develop and own those core competencies. And a couple of the core competencies that I see for these organizations is, again, I said it's all about the data, and you need to have people who understand that data as a part of your organization. You also probably need to have people who know how to relate to providers to use that data to affect the change. And the last point on that slide is really from a outsource to experts. And in terms of supporting systems and technologies, from the cloud, whatever it is that focus on what your core competencies are, and then outsource to people who provide expertise that's not a part of your core competency. Moving forward. Key in this is performance management. And you started at the beginning in your plan by defining your objectives. You should be able to define your data requirements to support the measurement of your performance and manage and measure. So plan has measurable objectives. You need to ensure that the deployment of your technologies to support the capture of the data that you need to support this measurement. And in addition to capturing the performance, getting back to provider relations, how you communicate and using that information with your aligned incentives to affect change. And again, another thing that we mentioned earlier is leveraging best practice data and peer data, which has proven to affect change. Providers naturally are competitive. Let's move on. Moving forward, we know the beauty of the industry that we're in, the industry that I'm in, is technology and healthcare always seems to change. So in my mind, change is inevitable. And, you know, we're right in the middle of major systemic change. Planning is a requirement, and effective planning. It's not the old 5-year plan that we did 25 years ago. It's active planning, and it's, you know, planning and doing and measuring and changing. From a technology perspective, the foundation that my clients are using who are successful, architecture is a foundation that you need to do. Architecture is a component of technology planning, working with the business to understand the business requirements, building an architecture. And if you think of a house, you know, the plumbing, the electricity, the roof, to ensure that, you know, you meet your objectives, and using the information architecture to model the data to support the needs that you have, both from a care delivery and a population health perspective. Governance of these organizations, and, you know, we can talk about the business model governance. I'm also talking about the technology governance. So you're building a plan, you're selecting technology, you're managing the deployment, and these are very complicated organizations. Having active dialogue where people participate, because it's important to participate and participate on an ongoing basis. Partnerships with key service providers, making sure that you understand what your needs are, your core competencies I mentioned in the last slide, and then, you know, partnering with organizations that provide you with expertise that you're not going to have to manage or have internally. But those key service partnerships, again, the same way, measured and managed, and ongoing dialogue, and, you know, the whole concept of vendor management is extremely important. Aligning incentives for these organizations, especially when these organizations are one organization, and then managing performance key to success. So, you know, I talked a lot about business drivers, information requirements, data, and key to success. I didn't talk about a specific technology because there is no one technology that's going to make these organizations successful. It's working with disparate technologies, making information interoperable, having that information follow the patient through the care delivery process, the ability to aggregate that data, use that data in analytical models to manage the health and the population, understand the risk of the population, and then use that data to manage the performance of your effort. Now, we probably were a little disjointed in this presentation. Hopefully Tom's back on, and whether or not he has some things to add. Or Chris, how do you want to handle that?
Yeah, so Bob, first of all, thank you. Tom was able to rejoin us, so I'm going to actually zoom back up to
Chris, I think
his
if you go to slide number 10, or actually slide number 9.
Okay. Oh, 9 appears to have disappeared.
Oh, okay.
Is this the one you wanted?
Yes, that's the one I wanted, yeah.
Okay.
I want to point out, and I'm sorry for the interruption, I'm not quite sure what happened with the reception, but suddenly it was gone. I want to talk a little bit about the providers that are launching plans and who are some of the more successful participants in the provider-owned plans. Certainly Geisinger in Pennsylvania and the University of Pittsburgh Medical Center, Henry Ford in Detroit, Baylor Scott White in Texas, and then in Wisconsin, we're seeing a third of the health insurance market is now controlled by provider-owned plans, and we've got over 900,000 enrollees. Finally, I want to mention Intermountain, and I think Intermountain is important for a couple of reasons. Earlier, I talked and Bob mentioned the difficulty in achieving success in this payer-provider integration marketplace. And with Intermountain, it took them 6 years before they were even able to break even. So the The push towards payer and provider integration, as Bob mentioned, it's not an easy road to travel, but it's a road that more and more government payers and commercial payers are pushing us down that road, so to speak. I'll close out in the few minutes we have remaining before questions, talking about the shift to value-based care and what's driving. And right now, the current system is the fee-for-service model, and that really doesn't offer incentives for improving quality or lowering costs. The incentive, it actually incentivizes physicians and their hospitals to go for volume. The more patients you treat, the more you get paid. So that is shifting now as everyone becomes concerned with rising costs and poor performance. So not only the employers, but the health plans and the government purchasers of health care are pushing for a transition to this value-based payment models. And as Bob mentioned, data is really important. And in the private sector, there seems to be a paucity of data. And that's demonstrated, I think, when you look at the Medicare programs, where hospitals submit yearly data cost reports that compare the actual costs incurred by the hospital with the amount paid for the services. That seems to be lacking in the non-government payer sector. Physicians really have no way of knowing the costs associated with the treatment protocols. And the historic model, at least with some of the payers, was not to collaborate with the providers because they viewed that data as being their proprietary information, and they didn't want to share it with the providers. So I think everyone is coming around to the position, however, that the only sustainable way to reduce costs is to start analyzing what it actually costs to provide that care, and let's focus on those 10 or 20 procedures that exhibit a lot of variation. I think the University of Utah did a study where they looked at the variations in their physicians doing a simple appendectomy and found considerable variations in what the physicians did and when they did it and how they did it. And by focusing on a simple procedure like that, they were able to dramatically reduce costs and increase quality. And then finally, I want to talk about the value-based payment models. I've put 4 up here on this slide. This slide is by no means totally inclusive, but these are the 4 major payment models that we're shifting to. So a bundle payment is simply a reimbursement model that's aimed to reduce costs. And what it does is instead of paying each provider separately for the care that they provide, it pays a collective group of providers, one payment, and that payment is shared amongst all the providers in that group. The idea here is to create shared accountability so that everyone from the surgeon to the anesthesiologist to the rehab therapist, if need be, they're all sort of working in tandem to make sure that that patient gets the best care. The model is really aimed at chronic disease groups, diabetes, COPD. Those are the patients that are the most active in the healthcare system, and by managing their primary condition, it's also going to lead to a reduction in complications from those primary medical conditions and hopefully lead to lower costs. Another area where we see bundle payments coming to prominence is in joint replacement. Medicare's got their comprehensive joint replacement model, and that's basically a bundle payment for a hip and a knee replacement. A shared savings, shared risk model is a total cost of care. And here, again, the aim is to reduce overall spend. So the providers and the payers are going to enter into a payment scheme, and it could be fee for service or it could be capitation. It just depends on the specifics of the model. But the providers are held collectively responsible for the total expense of treating a given patient population. The goal here is, again, to show a reduction in spending relative to a benchmark budget that's established up front or to a population control group. And so it's important in these types of plans to specify what the goals are. What are we going to be measured against? That way everybody knows at the beginning what they're going to receive at the end if they're successful. And getting to the end then, if total spending is reduced at the end of the year, then the providers are going to share in a portion of that reduction in expense. Pay for performance, I mean, you hear so much about that these days. It's essentially a mechanism by which quality and payment are tied together. It can take the form of a simple bonus for providing preventative care, such as flu shots, childhood vaccinations, annual wellness visits, or it can also be a more enhanced program wherein the participants are measured against baseline quality indicators before they become eligible for any shared savings or bonuses for improving on quality. And the final one up there is global capitation. I think we all thought that capitation, at least out here in California, kind of died, but it didn't. It's still available, or it's still active, and it's one of the payment models, one of the bundled payment models that is becoming more and more prevalent again. And here it's there's a little twist on it, is that there's a PMPM payment that's paid to the individuals, paid for all of an individual's care, I should say, regardless of what services that they use. So with that, I think we have about 5 or 6 minutes for questions, and so I'll turn it back over to Chris to manage that process.
Great. Thank you, Tom, and thanks for being flexible. I know we had to condense a few things. I'm gonna skip ahead towards the end. We have received a few questions. I'd like to also offer just a minute, if you have anything additional, to go ahead and submit those either through the chat or through the Q&A pane. And while you're doing that, I do want to mention the HCEG forum coming up to again extend the invitation to join us at the annual forum, whose theme is healthcare innovation, the new norm. It promises to be timely and relevant, and will be held in the heart of healthcare activity in New York. Registration will be open next month, and for additional forum information and any questions you may have about HCEG membership, please contact Juliana Ruiz at jr@hceg.org. That's jr@hceg.org. And just to answer some off top, so we are recording this webinar, and hopefully we'll be making the recording and the slides available in case things, because I know we had some technical issues, and also just in case we weren't able to be here for the whole thing. So those will be made available. Now, some of the questions. First one, I think this is for Bob. Bob, a little in your presentation, you did mention some standards. I think, if I recall, it was CDA and CCV. Are those the extent of the standards? And then the second follow-up to this is, how mature are these standards?
So I just make sure that there's so many acronyms we use. So CDA is a clinical document architecture, and CCD is a continuity of care document. And the CDA is the overall architecture of clinical documentation that's required. That's being governed by HL7, and the CCD is specific contents within the CDA. Again, HL7 standards version 3, and the issue is that 3-4 years ago there was still a continuity of care record, a continuity of care document. We're settling on the CCD as a continuity of care document underneath the CDA. The other thing to mention is FEAR, which is fast interoperability healthcare resources. I think that's the right acronym, and that's how you implement, and the CDA is the payload. So they're still kind of new, and the vendors are still working towards those, but those are the standards for interoperability.
Okay, thank you. I think the next one, I think I'm not sure if it's directed to Tom or Bob, so I invite Tom, if you want to answer first, and Bob, if you have any follow-up comments. If payers and providers are finding ways to integrate and align, but providers are also applying for insurance licenses, what happens? Do we see mergers with payers and providers? Do you see increased competition? I think it's really what outcomes, it could be how the market's trending or what have you.
Yeah, I'll start off with that. I think this is Tom. I think the answer is all of the above. Optum, which is a subsidiary of United Healthcare, is very active in the acquisition of physician practices and hospitals here in Southern California. They've, all over the last couple of years, acquired some of the larger multi-specialty groups in Southern California. They've also acquired some large IPAs. So that is certainly a trend that we see. We're even seeing, in certain instances, private equity becoming involved and sponsoring and helping to finance some of these acquisitions. Cerberus Capital acquired a Catholic health system maybe 3 or 4 years ago. I kind of thought that was a little irony there. You have Cerberus, who is the two-headed dog that guards the gates of Hades, acquiring a Catholic healthcare system. So certainly strange bedfellows indeed. There is going to be competition. I think there may be some conflicts of interest as well. One of the things that I was mentioning just before I was cut off was the conflict that's set up between negotiating lower fees, lower reimbursement, and asking the providers to invest significant dollars in IT infrastructure to successfully manage population health. So, yes, I think there will be competition between the various players, both on the provider side and on the payer side. Bob, if you want to add anything.
I think it's really interesting because we're seeing, and again, it gets back to the dynamics locally and what's going on, but we've seen everything. Providers starting health plans. In my market, Western New York, we see more alignment in providers working with health plans and division of responsibilities and the model designed to support those division responsibilities. But we're seeing everything.
And we're at time, but very quickly I want to throw this last question out here. So just if you have a quick response, given everything we've talked about today, and also thinking about the ACA, how narrow will narrow networks end up getting?
But that's a difficult question to answer. From what I see here in Southern California and to a certain extent in Northern California, there's a limit to how narrow you get, because I think the patients are going to push back and they're going to demand greater access. I think the government will also, at least for the plans that they're paying for, we're already seeing that, wherein they are saying, look, you can't limit access. You have to provide a little wider area network so people can continue to see their physicians, continue to go to the hospitals that are closest to them, and get the ancillary services that they need. So I think market forces and government regulation is going to limit how narrow the networks become.
Bob, any final words?
No, I think that thank you.
All right, wonderful. Well, Bob and Tom, thank you again for your insight today. I know I got a lot out of it, and we had some very nice comments from some folks who attended as well. And thank you to all the attendees for joining us in this part of this HCEG webinar series. And again, there's the information for the upcoming forum on the board, as well as how to contact Liliana for more information. So thank you very much, and have a great rest of your week, and enjoy Memorial Day. Thank you.
Thanks, everyone.
Thanks, everyone.